Welcome to today's webinar of the National Health Quality Roadmap. Dr. Peter Pronovost from the University Hospital Health System in Cleveland, Ohio is our guest today. Dr. Pronovost, a world-renowned patient safety champion, innovator, and clinical care physician, serves at the University Hospital as the Chief Clinical Transformation Officer. He's also the clinical professor of anesthesiology and critical care medicine at Case Western Reserve University. Dr. Pronovost is the co-chair of the National Quality Summit. In addition, Dr. Pronovost is the policy co-chair for Premier's Chief Quality Officer Affinity Group and is instrumental in guiding the improvement work of this group of academic chief quality officers from across the country. Joining Dr. Pronovost is Carolyn Scott, Vice President of Premier's Academics, and she will be serving as the moderator for today's call. At this time, we will turn the call over to Carolyn.
Welcome to today's webinar. Dr. Pronovost, we are so grateful that you've taken time out of your busy schedule to share information about the important work you co-led, which stemmed from the President's June 24th, 2019 Executive Order, Improving Price and Quality Transparency in American Healthcare to Put Patients First. For those who may not be aware, can you provide a high-level overview of the background and output from the National Quality Summit that launched last year, as well as the Quality Roadmap, which was publicly released in May?
Yes, sure. Thank you. As you highlighted, the President gave an executive order to focus on price transparency and to look at our quality strategy for this country. As many of your viewers know, our quality is far from where it could be. People suffer harm too much, we learn and improve too slowly, and healthcare costs too much. And yet, despite that, we looked at how many measures we collect through HHS, and it's over 2,400 measures. I mean, so the burden of many of these measures is quite significant. Many clinicians perceive the validity of them as being low, and no doubt measurement has improved significantly over the last decade, and CMS should be applauded for their work. That said, there's still an opportunity for us to really focus on measures that are meaningful and to relook at the strategy. So the summit was an opportunity for us to do that. We were charged with producing a report in 180 days. And as you could imagine, looking at the entirety of the quality measurement enterprise in 180 days is kind of a Herculean task. To guide us, we formed an 18-member private sector panel that advised us on this work that we met 3 times over the course of 180 days, as well as having an internal government panel to guide us, because this wasn't just CMS, it was quality measurement across all of HHS, and that includes DOD, the VA, AHRQ, HRSA, as well, obviously, as CMS is the largest player. Through this work, we came up with 3 key themes that the roadmap needs to address. The first theme is focused on enhanced governance. That what we found was that many of these measures evolved over time without necessarily coordination or a governance oversight, and certainly probably too little private sector input. So you end up with these 2,400 measures, and it was even hard to have a grasp of what the totality it was. That may sound trivial, but even finding out how many measures that we have, was really quite a large effort. What we recommended in the roadmap, and it's being implemented now, is that we would put an transitional governance group together that would plan for a more private sector long-term oversight group, very similar to what exists in the financial sector through the Financial Accounting Standards Boards, where it's a private sector rule setting, private sector auditing, which, as you know, healthcare doesn't do right now, public sector transparency, so you can go on EDGAR and look at any company's financials, and there's a common book of truth, and then private sector reanalysis of the data to add context or storytelling, much like a Bloomberg or a Reuters might do to say, if I'm interested in small cap environmental companies, there's a culling of that information and helping to enhance the meaning of it. We don't have that kind of support or that private sector leadership in healthcare, and that was a key theme. Second theme was an investment in our data infrastructure. There's been, I think, preciously limited data into the infrastructure, a lot of work on data interoperability and creating standards that make data sharing possible, but the backbone of how to do that, how to reduce the burden on provider organizations that are submitting data, how to make it more facile and readily accessible in real time and not have an 18-month lag like so many of our measures have now, it was a key focus. And the third is focusing on measures that matter. And that's building upon some of the great work that CMS is already doing to both reduce the burden and increase the meaningfulness of measures, and importantly, start to think about or evolve towards measures of value. You know, we know we're evolving our payment system from a payment system focused on volume to focused on value, but we didn't create a mechanism to create measures of value, and that is measures that cross the continuum of care. So for diabetes, for example, not just is their A1C controlled, but perhaps also have we accurately diagnosed them? Have we avoided needless ED visits and hospitalizations because we have them controlled? So those were the three themes that emerged. There's an internal government work team now that's coming together. As you can imagine, COVID stalled a lot of this work to help trying to make sure we make progress and address all of these recommendations.
Wow, a lot of work that's taken place within the last year. And when you say Herculean effort, I would say that's probably an understatement given the task that you all had at hand. When you look at those three primary areas, from oversight to data infrastructure to measures that matter, which do you think will which do you think will get done first, and which do you think will take a little bit longer to effectively roll out?
Yeah, great question. I would say that they probably vary in their complexity. The first one is much more politically complex about how do we create a vehicle to have a more robust public-private partnership and more private sector oversight of that, and exploring whether that's partnering with an existing organization or bringing several organizations together or creating a new organization to do that. I mean, the hopeful thing was that there was unanimous agreement that we need new governance, that, you know, that we can't have all these measures popping up with, you know, without coordination or even understanding of what they're measuring and making sure there's standards for how accurate they work, just as our financial reporting, you know, has worked. You know, if you may remember, prior to the SEC that was created in 1934, there was no standards in what a company reported in its financial statements. I mean, they could literally put any data element in any item, and it limited the ability to make investments and to grow businesses because you had no idea what was under the hood. And we need to evolve much like that same approach for financial reporting. The data infrastructure, I think, is just investments. And I don't mean just, but I mean, like, the science is there. There's a number of companies, many in the private sector. There's a lot of work in the public sector that have greatly advanced the ability to aggregate and integrate data. Indeed, Premier's doing amazing work in this space. And I just, you know, look at the capabilities Premier's developed over the last couple of years to, you know, your data infrastructure. And that same kind of infrastructure, I think, needs to be in our federal assets. One, I think, issue that we'll have to address is many people felt that we need much more transparency and publicly available of the information, and balancing the protection of the people whose data in there with the ability of more real-time access to data, and to have a playground where we could either use synthetic data or de-identified data to create a measurement lab, right? You know, right now, measures are very expensive to develop. The timeline's very long, but you can imagine you put data out there and make it accessible, that there'd be a whole lot of stakeholders that would focus on developing new measures. So if I'm a woman with breast cancer and I'm really interested in a quality measure for breast cancer, or someone with sickle cell disease, I'll make sure that we have the data to begin to develop that measures. The measures that matter, I think, is probably the most advanced. There's a lot of great work with many organizations coordinated by CMS and AHA to pull people together to drive a real focus on measures. And that work, I think, is underway, and hopefully this roadmap it continues to accelerate. When one of the debates that we had that underlies all three of these is whether we have too many or too few measures, right? And it's really quite a complex question, because if I'm to take the same example, a patient with sickle cell, there's no real measures for sickle cell. So in my case, there's too few, right? Or if I have a disease that there's no measure for. On the other hand, if I'm a provider system or an administrator and I have to submit 2,400 measures and I deal with the burden, then that is probably that there's too many measures. And in some ways, I think that's a false dichotomy. One is there appears to be too many because we don't have a framework that all the measures hang into. So if we had a construct that had, okay, these are the preventive measures. These might be the measures of chronic diseases. These may be the measures of helping people manage an acute illness. And then I could cascade a library under there. It may appear a lot less overwhelming. Also, we had a lot of discussion about separating measures for accountability for measures for learning. Right? One thing we know is the measures for accountability are important, but we may not need very many of them. But the measures for learning and improvement likely need to be much larger. So if I'm a health system, I should have that flexibility to focus on measures that are most important for the communities that I serve or the people that I serve. And that will likely be highly variable depending on where we live and the type of people that are in your health system.
Great. And I think what you point out about measures for accountability as well as measures for improvement really takes us back to one of the guiding principles that you spoke about earlier, and that was reducing the time lag for data acquisition for action, if you will. And as you pointed out, there are some metrics that do have that 18-month time lag. What do you see as key priority activities to help shorten that time lag in terms of data acquisition and feedback and reporting?
Yeah, I mean, the technical ability to do this we have right now. I mean, it's not, again, I go back to Premier. I mean, there's mechanisms to submit data, to get it in a database and in near real time and get access to it. I think there's strong agreement amongst all the partners that we should have more timely access to valid data. Consumers should have more timely access to valid data. And so we have the political will for that. I really think it's just doing the plumbing of the data architecture and thinking through this in new mental models of let's break out of the old ways of here's all the steps that have to be going in place before we could report these data to, using some modern data science tools to get it into the hands of people who can use it to improve. Because as you may know, data that's at 18-month old, you could use it for payment, but it's almost useless for motivating behavior change or for improving care. I mean, imagine going back to a bunch of clinicians and say, well, here's your quality score 18 months ago. And like, okay, well, what do you want me to do with that? The patients are long gone. Many times things have changed, and yet we spent all this effort collecting and reporting that data. It's a very different discussion about, hey, here's your data from last week or from last month even. And I also think it's a tribute to our provider communities because, early on in the quality movement, there was a lot of what we might call the ostrich effect, right? Oh, the data's terrible. And many times it was. And, my quality's good. I don't buy into the data. Leave me alone. And I think we've gotten past that. And to the regulators' credit, they couldn't stand by the ostrich effect because there was compelling data that many people are suffering harm and we're wasting a lot of money in this. And so they ratcheted up their infrastructure to collect quality measures. I think the providers now have really matured and have accepted that value and improving quality are our responsibilities. We have to own it. We want accurate data. We're willing to take responsibility for it. And now we have to make sure that we provide them that enabling infrastructure, which are the tools, the valid data, and the feedback so that they could indeed drive improvements.
Could not agree more. Thank you. So some specific direction from the executive order obviously focused on this establishing common quality measurements, but there was also work to be done around aligning inpatient and outpatient measures and eliminating low value or counterproductive measures. Given where we are today, how do you see those two aspects moving forward?
Yeah, great question. And let me just share with you at least some reflections on what COVID highlighted about the measures that might be less valuable. You know, during the pandemic, as you may have seen, there was a suspension of many quality measures because of their burden.
Correct.
And on the one hand, you know, that's laudable because they are burdensome. But let's think for a second, do you think any hospital would say, we're going to stop financial reporting because of COVID, because it's too burdensome? I mean, quite the opposite. If you have dashboards, they're even more important during a crisis because you need your North Star. You need to be navigating about where you're going, how you're providing care. And I think what, you know, that suspension said that perhaps these measures aren't as meaningful as they could be because we wouldn't want to suspend them. We would want them to use to guide the very care that we're providing to our patients. And I think that was quite telling. There's no doubt that the usefulness of measures vary widely, in part because of their variation in how we approve measures. And you know, though many of our measures are approved by NQF, the standards or the rigor of that approval varies widely, and there's not, you know, explicit quantitative criteria, for example, that says a measure that is an outcome measure needs to have these performance, or a measure that's a process measure needs to have this rigor of evidence supporting it, or a measure that's from a survey measure needs to have these psychometric properties. Early on, there was some movement to be more rigorous. I think the field just wasn't as sophisticated in the beginning, and it went to more just a principal approval. And I think there's no doubt that we need more rigor in this. And it may even be, there was a lot of discussion of, much like Amazon or many of these are, you know, a restaurant rating app where providers could rate how valid is this measure, how important is it, and we could have some thresholds to say, hey, we're going to focus on measures that meet some standards for perceived validity or perceived importance, because otherwise we're spending a lot of money on measures that aren't being used to improve.
Do you see the FASBI-like oversight board getting heavily involved in this type of aspect, helping identify which of the metrics are, in fact, more meaningful than others?
Yeah, that's a great question, and I believe that's the case. And let me just give you an example of how I think the wisdom of a FASBI-like measure. When FASBI was created, they didn't define 5 or 6 or more explicit financial ratios that we were all going to look at, right? The quick ratio, whatever ratio you want to do. What they, I think in their wisdom, said, we're going to define a standard set of data elements that have to be submitted in a standard way. We are going to audit them to make sure the data is truthful so people have trust in it. And we're going to put that data publicly available. And admittedly, it's a little bit clunky and clumsy, but then we're going to open it up for the market to make measures and to innovate for new insights into financial performance, right? And as you know, we constantly have new performance of financial measures. The system evolves, and you know, different groups have different ratios that they're used to insights. There's a whole industry now of financial journalism that you know, you can pick a newsletter, and if you're interested in any topic of, you know, as I said earlier, you know, healthcare stocks in Northeast Ohio, there's enough interest, somebody will write a newsletter to create that information. And I think that kind of stimulation is what something like a FASBI could do, where we could standardize a set of data elements, ensure their accuracy, perhaps convert them into some base set of measures, but then let people innovate to get measures that are meaningful to various groups.
Great. So a little bit different spin given the pandemic. Are you hearing about a push for any new measures on the horizon which would specifically address infectious diseases resulting from epidemics or pandemics?
Yeah, great question. And as you know, our report was submitted in January to the president, or actually, excuse me, end of December. It was just made public recently because it had to go through some reviews, and quite frankly, we weren't sure how to make it public with the overwhelming pandemic that health systems were beginning to face. But one point that the pandemic highlighted is how the quality measurement enterprise missed the whole idea of a pandemic. I mean, we don't have standard measures of thinking about pandemic, and I believe there's pretty broad support to say that the quality measurement enterprise needs to be broadened to include a pandemic. And it also highlighted some enormous gaps in our data infrastructure and our quality measurement systems, particularly around skilled nursing facilities and congregate living. The ability to collect data from those facilities is really challenging for many health systems, for many states. The relationship between the hospital system and the skilled nursing facilities is often very limited. And much of the data has been collected on paper and pencil. I mean, literally that's how we're monitoring it. And so I think yes, without a doubt, the pandemic highlighted the need and perhaps the urgency to address all those themes that we highlighted in our report about better governance, better data infrastructure, and more meaningful measures.
Great. You've been involved and a leader in quality improvement and accessing data to help drive improvement in patient safety for a long time. As you undertook the work relative to the summit and the eventual production of this great report, were there any surprises or any aha moments for you?
Yeah, there were several. One, and it was, really quite heartwarming, was there was almost unanimous consensus about the importance of quality measurement and how it needs to be simplified and made more meaningful. And, and at first, leading this summit, as you can imagine, is quite a political process. And, every word matters because people are interpreting it, things in different contexts. But people really came together to say, yes, we need to make this it better. It's got to serve the American public better. It's got to serve our providers better. And that alignment, was, I think, much more than I thought. Now, obviously, it's much like making a budget. Once you get into the details is when the arguments, that people start to disagree. But that was what was really hopeful. I was also quite heartened at the alignment about those three recommendations. There really wasn't much pushback, even for the governance piece to say, yes, we need a new governance with a greater private sector voice. The infrastructure, I think, was also strongly endorsed by everyone, and the measures that matter. So that was, I would say, two of the surprises. One, and maybe it shouldn't be a surprise, was early on in the process, we asked the question, so just how many measures does HHS collect? And may sound surprising, but that wasn't the easiest thing to find out. I mean, because they're all over the place. And another insight that we're trying to tackle and the report addressed is when you look at much of the burden of measurement, much of it is driven by not so much the number of measures, but how every subgroup tweaks a measure that it becomes a little bit different, but I need a whole new data collection mechanism to do that. So, for example, you could take a diabetes measure that CMS might use, and every state tweaks it a little bit for a variety of reasons. and every insurer tweaks it a little bit. Now, from a methodological or research perspective, that tweak does almost nothing to add new insights or meaning. It's, somebody wants to delete a population or include something. And even if it is potentially somewhat meaningful for the states or for the people they serve, the net negative impact is I've just exponentially increased the burden on health systems, because for every one of those payers, I need to create a new data collection mechanism, right? To get all that data. And it might as well be a brand new measure, because I have to build, new mechanisms for health systems that care for patients in many states. It greatly adds to their cost because they have to build mechanisms, and the value that tweaking adds is negligible. And so we hope there'd be some part of this governance will be corralling or bringing together the states and the private sector insurers to say, of course you need the flexibility to tweak things, but be really mindful that you're really adding the burden. So let's make sure the benefit is there to offset that burden when you're tweaking measures.
Wow. Great. Thank you for sharing that. So when you think about where we are today as an industry in dealing with the pandemic and its many ripple effects, what, in your opinion, are high priority areas to be focused on next, beyond those addressed in the roadmap?
Yeah, I think without a doubt, skilled nursing facilities and congregate living places is a priority. And in some ways, I could see that skilled nursing facilities being a example of how this new roadmap could be played out, of making sure there's a governance for data collection, there's an infrastructure for data collection, and we focus on measures that are meaningful for the people we serve. I think second is measures across the continuum of value. Many of our measures are still facility specific. So we have hospital measures, we have ambulatory measures, we have skilled nursing measures, we have home health care measures, and we will need some of those. But what people want, what you want, is measures across the continuum. How do you keep me healthy if I'm working with you? How do I make sure that the diabetes care is I'm good? A big barrier to doing that is making sure people are attributed to a physician or to a health system, so I could monitor people over time. Because when people bounce around amongst different health systems, it's really hard to collect the data. You could get it from federal data systems, but one health system won't have that data. But it's also really difficult to aggregate data over time to show, hey, this is how well I'm keeping you healthy for, this population of patients.
Wow. Yes, I think really some of the things that you've just called out, I'm sure we're probably already on your radar, but probably increasingly magnified by what the country's been dealing with and what they've seen as a result of the pandemic. So before we wrap up, anything else?
I would just add, there's one other data and quality measurement opportunity that was raised by this that I believe we will see great acceleration of, and that is what I would call a systems operations center that could start within health systems but aggregate it to state and national level. And I know Premier and the team are working on some of this, but let me give you an example. In many of our health systems, when COVID hit, we struggle to even know how many ventilators we have, right? Let alone when a patient was on a ventilator, or if they were on the ventilator, if they're receiving therapy to compliant with best practices. We didn't know the status of how many patients were on our monitored beds. We might not know the length of stay or the occupancy. We might not know how many patients are on our home monitoring system. And one of the things we were doing here at UH, and I think you're seeing around the country, is to begin to create system operation centers that not only ingest the data to give you real-time insights about your occupancy and your operations and giving care, but also then linking it with an operating model that allows you to manage that in real time to get your length of stay down, to make sure that you're getting as many people out of the hospital as home so that you can build capacity, that if you're in the ICU, you're really getting the best evidence. Let me give you an example. With the ICUs being overrun, meaning the US had ophthalmologists and obstetricians providing care to ICU patients, right? On the one hand, that is helpful, but on the other hand, to say, well, how do we then ensure that they're getting evidence-based therapy? Well, there's systems now where you could link the ventilator, the EMR, the infusion pump, and write guidance that you can make sure from any command center that patients are getting the recommended therapies in real time. And if they're not, alert the clinicians to say, here's what you should be doing to provide that excellent care. And I believe one of the outputs of COVID will be a greater acceleration of these system operation centers that ensure high reliability medicine.
Great. That's wonderful insight. Wonderful insight. So now that the report has been publicly released, are you continuing work on the effort, or have your tasks pretty much been completed at this point?
No, they have. I agreed to stay on and to co-chair the report. I will be doing it as a civilian, so my kind of official appointment as a government employee has ended, but I stay as a volunteer and helping to advise HHS on this really, really important work. And I really applaud the HHS and its leadership for tackling this really important effort, because all of us who live in the healthcare quality space realize both how important this roadmap is and how much improvements in quality are needed.
Great. Well, before we wrap up today, any final thoughts, comments you'd like to share?
Yeah, my final comment is that I hope all the Premier members engage in this report and work collaboratively to improve the quality measurement enterprise, because remember that these measures are only a means to help improve the care for those patients that we are so fortunate enough to serve.
Great. Well, Dr. Pronovost, I'd like to personally thank you for taking time again out of an incredibly busy schedule to update us on all the great work that went into not only the summit, but the production of this outstanding report, one that obviously has recommendations which are greatly needed. Your service to this country and to healthcare, specifically in the areas of safety and quality, cannot be understated, and just so grateful for all of your contributions. So thanks again for joining us, and have a great day.
Thank you, and same to you.
Okay.